Good morning, everyone. Welcome to Surgery Grand Rounds. I'm Dr. Pratt, and I'm going to introduce myself. I'm Dr. Pratt. You can call me Janey. I've been at Stanford since 2017. And since at the end of my talk, I'm going to talk about all that, I think I'll just get started since it's a pretty long talk and I want to have time. But today, what I hope you will get out of the talk, first of all, let me tell you my disclosures. I have consulted for intuitive surgical, Medtronics, and applied medical over the years, but the most important thing is that I love children. I always wanted to be a pediatric surgeon. I actually have 4 boys and a very wonderful husband who are pictured here, and I have a granddaughter. So, and I work part-time, and I have since I started. So the objectives today are to understand pediatric obesity and its comorbidities. This is Pediatric Obesity Awareness Month, if you didn't know, so that'll be good. And I want you to know the guidelines for using metabolic and bariatric surgery. I want you to be able to describe the different operations and their roles in the treatment of pediatric obesity. And then finally, I want you to realize that you can get to where you want to go with perseverance, time, and a little help along the way. So I'm just going to talk a little bit about my life and how I got to where I am at the end. So what is obesity? In children, it is a BMI above the 95th percentile, and it starts sometime in childhood, pediatric obesity. It can start at 2 years old, and it looks like this. It's a growth curve that no longer follows a curve. It's a straight line up. It's more like an acceleration than a velocity. At 8 years old, it can start, or it can start at 12 years old. And you'll note that all of these kids had obesity before they started developing that straight line up. So they're all overweight, they all have obesity, and then they get to this point, there's an inflection point where they start to gain weight, and it doesn't stop. So it is a medical condition. Since 2013, believe it or not, that recently, the AMA recognized obesity as a disease. It is a disease of excess energy storage. And it's estimated by the BMI. There have been a lot of articles about BMI being a bad estimation. It's not great, but it's what we have, and it's easy to measure. It's your weight in kilograms over your height in meters squared. There are plenty of calculators for it online, and it gives you a sense of how much body fat a person has. We also check a DEXA scan, which will tell you what percent total body fat a person has. And if you put those two together, you have a perfect measure of obesity. Severe obesity in children is defined by the 95th percentile, so it's greater than 120% of the 95th percentile, or greater than 140% of the 95th percentile, and those correspond about to a BMI of 35 and 40 in the adult population. So why does BMI matter? Doesn't matter if you're too tall or too tall. Doesn't matter if you're really tall or really short. You know, that doesn't matter. But why does BMI matter? BMI matters because increased BMI leads to early mortality. And this is true in adults. This is an estimation of the adult population calculated by Dr. Schauer. And then this is actually a Swedish obesity study in childhood, which showed that as early as age 20, you start to see a divergence in the line of survivability in children with obesity versus normal weight children. BMI leads to many comorbidities. There are over 200 other diseases that are caused by obesity. And some of them are very specific to children. For example, pseudotumor cerebri is much more common in children. Slipped capital femoral epiphysis or Blount's disease occur only in children. And children have much more severe type 2 diabetes. They might have almost every child, 70% of the children who come to us already have insulin resistance, and 10% have diabetes. So what are the consequences of comorbidities? If obesity is left untreated, many of the obesity related comorbidities are going to lead to surgery. Idiopathic intracranial hypertension might require a shunt. Sleep apnea might require a tonsillectomy. In fact, it usually does in children. There are orthopedic complications I already talked about. There's type 2 diabetes, which eventually leads to kidney failure and retinal disease, and it leads to that much faster in children than it does in adults. Metabolically associated steatohepatitis is the leading cause of transplant these days. Hypertension and dyslipidemia can lead to coronary artery disease. And finally, cancer is caused by the inflammatory state of obesity. In fact, the leading reason why metabolic and bariatric surgery in adults leads to a longer life is because of the decreased cancer rates. So what causes obesity? You know, is it eating too much? Is it not exercising enough? Is it under volitional control? Can you actually control your weight? It ends up that obesity is controlled by a thermostat, a metabolic thermostat that's in your body that determines how much of what you eat gets stored as fat. So the examples here are my second son, Max, who can eat and does eat 4,000 calories a day and has a BMI in the 5th percentile. That means he's skinny, if you can't tell from the picture. And he's always been that way. Whereas I have patients who eat 800 calories a day and have severe obesity, who weigh over 300 pounds. And I ask the kids, I say, do you have a friend or even a sibling or a parent who can eat anything they want, all the candy and pizza and sodas, and not gain a single pound? They're super skinny. And yet for you, if you smell pizza, you gain weight. And all of my kids, not my personal kids, all of the kids that I take care of can relate to this. So obesity is not the child's fault. It is a genetic problem. It is a genetic disease. And it's not their parents' fault. It's not their parents are feeding them too much. They're hungry. They want to eat. They end up gaining weight because everything they eat gets stored as fat. Childhood obesity causes significant depressed quality of life. Obesity in children actually causes significantly worse quality of life than children with normal weight. And in fact, the health-related quality of life is similar to that of children with cancer. 30% of the kids that come to our program already have depression or major depression, and most of them have been bullied. There's good news, everyone. It's okay. I do have good news. Metabolic and bariatric surgery works in children. The benefits of surgery far outweigh the risk, and the medical community and public are starting to recognize this. So I know I just painted a horrible picture of what obesity is like and what obesity is for children, but the fact is that we actually have treatments that work. The ASMBS guidelines recommended surgery as the best treatment for severe obesity. Of course, I wrote them, so I could say that. They recommend it for a BMI of 35 or 120% of the major, with a major comorbidity, or a BMI of 40 or 140% of the 95th percentile. Since then, in 2019, the American Academy of Pediatrics came out with a position statement, and they basically supported the same exact criteria. And they said that age should not be an indication against surgery. In other words, we shouldn't be using age, we should be using BMI, which makes a lot of sense. They then came out with the clinical practice guidelines in January of 2023, and they had some key action statements, which may seem obvious, but are actually not what the AAP recommended before, i.e. you should treat obesity. That was the key action statement that I found the most difficult to accept, because it ends up that the AAP had recommended watchful waiting for obesity in children. So it was like, oh, it's baby fat, they'll outgrow it. And which is hard to even imagine when you look at those growth curves, but that was what was recommended before. So now they say that you should treat it, they say you should use anti-obesity medication, and they say that you should use surgery. So what are the treatments? We have surgery, which works quite well. You get 25 to 30% total body weight loss. Medications can lead to 5 to 16% total body weight loss. And lifestyle programs will cause about 1 to 2%, and that's all shown in these curves over here. These are, this is lifestyle, this is medication, and this is surgery. But the truth is that most children presenting with severe obesity are referred late. So all of those growth curves were real children, and they were all when they presented to me. So, and you saw the BMIs were 60, 50, and 65. So most of them are going to need all three: medication, surgery, and lifestyle programs. And let me give you an example of this. If you take patient number 1, this patient has a BMI of 31 at age 10. That is 140% of the 95th percentile. So this patient would qualify for bariatric surgery. And if we start the lifestyle program, which we always start first, And then we could either add medications, which will get the patient's weight down a little bit, or we could do surgery and get them down to a normal weight. And after they get to that normal weight, they grow along the growth curve. Works great. So this is the age where we have an opportunity. So let's see, the most common patient I see is actually this one, which is the same patient 5 years later. So if I see this same patient 5 years later, they're age 15, they have a BMI of 50 now because they've grown in that straight line. And this is a real patient. I didn't make these dots. Well, I did, but this is a real patient. And then you use medication, you use lifestyle, you use surgery, and you can't get down to a normal weight. You have to add medications. So this patient is now going to be on medications the rest of their life, and their BMI is still higher than it would have been if we had done surgery when they were 10. So for which children do we recommend surgery? Any child whose BMI meets criteria. They need to have psychological clearance by our psychologists. They need to be well-informed and motivated, and they need to be in our program every month. We meet for 4 to 6 months before surgery. And then they have to go before a bariatric committee to approve readiness for surgery. And what surgeries do we use? How do they work? I'm going to talk a little bit about each of these operations. This is a gastric bypass, a sleeve, and a biliopancreatic diversion. We used to think these worked by restricting intake and causing malabsorption. It ends up they don't work that way. Maybe 10% of the weight loss is from restriction, but most of the weight loss is from hormonal changes in the gut hormones that signal the brain, hormonal changes in the brain that signal the brain to feel less full, more full, less hungry, and also to metabolize differently. So instead of storing everything as fat, they stop doing that. It basically resets that set point. It turns down that thermostat I was talking about. It changes their behavioral response to food, and they lose weight. So the gastric bypass has been around since 1967. It was invented by Dr. Mason in Iowa, and it became a laparoscopic procedure in the early 1990s. And that happened simultaneously in LA by Dr. Whitgrove and in Sweden by Dr. Lonroth. Since 2014, until 2014, sorry, it was the most common operation used in children. So when I started the bariatric program at Mass General, I was doing these operations on kids. It results in about a 30% total body weight loss in adolescents, and that weight loss is maintained in 50% of the patients. Another 10% don't lose weight, they regain it. And then about 38% regain slowly over time. They may not get to their original weight, but they will regain slowly. Nowadays, we have anti-obesity medications we can use for those kids and prevent that from happening. It does have a 20% reoperation rate. The reoperations are for ulcers, kidney stones, gallstones, and bowel obstructions, like internal hernias, that sort of thing. And it has a less than 1% risk of serious complications at the time of surgery, a very low mortality rate, and it causes decreased ghrelin, so less hunger, increases GLP-1, PYY, oxytocin-modulin, and bile acids, which all act to improve satiety or a feeling of fullness. The sleeve gastrectomy was first done in 2002 by Dr. Gagne as a staged procedure to the biliopancreatic diversion. He started doing biliopancreatic diversions laparoscopically, and then he realized that there was a very high mortality rate when he was doing that in patients with a BMI over 60. So he said, well, I'll try staging it. So he took a bunch of patients with a BMI over 60, did sleeves on them, and they all lost weight. And he was like, whoa, this works really well. And so he called a group of people together in New York, and we all sat in a room and said, why does this work? And figured out that it was causing increased GLP-1 after another 5 years of study. And then it became a very popular operation. In 2014, it became the most common operation in adults and adolescents worldwide. It also results in a 30% total body weight loss in adolescents. You will see that that is different from adults later in this talk. It is, you do see inadequate weight loss in the same numbers as we do with the bypass. And it only has about a 5% reoperation rate, and usually it's for severe bile reflux, and it is converted to a bypass. And it works through the same pathways: decreasing ghrelin, increasing GLP-1, PYY, GIP. Oops. The next operation is the biliopancreatic diversion. That's been around since the 1970s. It was invented in Italy. It was modified to be a duodenal switch, which means that basically it's like the difference between a Whipple procedure and a pyloric sparing Whipple procedure. So the duodenal switch is the pyloric sparing version. And it basically is a sleeve followed by a intestinal bypass. It results in 35% total body weight loss. Inadequate weight loss in only 5% is the most effective bariatric procedure we actually have. But it does have a higher reoperation rate. It has a higher initial risk of serious complications. And there's a lifelong risk of protein calorie malnutrition. We try not to use it in kids. However, there are cases where it is useful, especially in syndromic obesity like Prader-Willi syndrome. These are the hormonal mechanisms, and you can see that the effects of the gastric bypass and the DS and the sleeve are similar, whereas the adjustable gastric band had no redeeming hormonal effects, which is probably why we're not using it much anymore. So what does the data show? In patients with obesity who undergo bariatric surgery, they live longer. This is the data. This is the only adult data I'm going to show. Everything else after this is pediatric data. In adults, if you operate on a patient who has obesity, you're increasing their life expectancy by 6 years. If they also have diabetes, you're increasing it by 9 years on average. The largest international study in sleeve children is a single center study in Saudi Arabia that looked at 2,500 patients. They had ages from 5 to 21, and 800 of those were under 14. The baseline BMI was 45, and the 10-year outcome showed a less than 1% risk of serious complications, and most of those were prolonged nausea and vomiting. Weight loss of 32% total body weight, which was better in the younger population. And then complete resolution of comorbidities at 10 years, including 72% of patients with diabetes, 58% with hypertension, and 57% with hyperlipidemia. And the patients grew to a normal height when compared to matched controls. So it doesn't stunt their growth to have bariatric surgery. And in the younger population, it looked like they actually grew more. They actually were about 1 centimeter taller than they were to be expected to be. The largest study in the US is the Teen Lab study, which was a multi-institutional study that took 5 institutions across the country. They assessed for safety and efficacy of weight loss surgery in teens. And they looked at ages 13 to 19. And this is where the AAP took their 13-year-old because they didn't look at any foreign studies. So that's why they made an age cutoff at 13. The median BMI was 53. And 76% were female, which is lower actually than the adult population studies, which usually are about 85% female. They saw significant improvement in comorbidities, significant improvement in health-related quality of life. They did see vitamin deficiencies, and they saw that the sleeve and bypass had equivalent weight loss at 3 years. And then at 10 years, the same was true. Sleeve and bypass had equivalent weight loss. But there was no difference in resolution of comorbidities, so diabetes, hypertension, triglycerides, all of that improved the same whether you use the sleeve or the bypass in kids. And if you use the sleeve, they are less likely to have B12 or ferritin levels that are low. And the data I was talking about before really came from this. At 6 months, you can predict which group the patients are going to fall into. So we very carefully monitor their weight loss at 3 and 6 months. And if they are falling into the groups that are going to regain weight or not maintain a weight, we will add medications or we will offer medications. They don't always want to add it. Sometimes they want to wait until they get to the lowest weight and then add medications, but we add medications. And if they're in the 50% that lose weight and are going to keep it off long term, we don't need medications in most cases. Although patients who are starting at a BMI of 60, they're still going to need medications if they want to get them down to a normal weight. So adults versus adolescents, these are my patients from Mass General. I actually am trained as an adult surgeon, and I've been practicing adult surgery until November of last year. But I'm now a pediatric surgeon only. But when I was doing pediatric and adult surgery, we took 75 of my patients from the adult and 76 who underwent sleeve gastrectomy. And what we found is that the adults don't lose as much weight. And the adults don't see as good a resolution of comorbidities. So the sleeve is a great operation, but the younger you are, the better it works. And the older you are, the less weight you're going to lose. If you look at older versus younger children, the outcomes are basically the same. We looked at long-term outcomes of 2,500 patients, and we found that the young ones, and this is Dr. Al-Qahtani's work again, he found that the young ones had the same weight loss as the older patients. So how do medications compare to surgery? The medications work. They're about half as good, as effective. And if you stop them, you regain the weight. So one of the nice things about surgery is that if you have surgery, you can't take it away, it's there. And so, if you lose your insurance, if you're transitioning like most kids do, away from their parents' insurance to their own insurance, they're not going to lose their access to what's treating their obesity. Whereas if with a GLP-1, they might. It also is more effective, and there's no long-term data in GLP-1s. We don't know how long they're going to work for. We don't know if patients will become resistant to them. We don't know if they'll cause long-term side effects. But we do know that with meds, they're going to lose 50 pounds, and with surgery, they're going to lose 100 pounds if they're starting at 300. So what's our pathway look like? We do a virtual teaching session similar to this, except I'm not standing at a podium, I'm sitting at my computer. And I basically present all the data I just presented to you, to the kids. I tell them, this is how it works. It's your choice. You don't have to have surgery, but this is how it works. Then we just got funding to provide a scale and a water bottle to each kid. So I'm super excited about that, because trying to get them to buy them, they can't always afford them. So now they'll have a scale and a water bottle. And then we initiate a lifestyle change. We have a no soda, no juice policy. And then we have the 60-60-60 rule, which is 60 grams of protein, 60 minutes of physical activity, and 60 ounces of water every day. It's easy to remember, and the kids are pretty good about doing it. So that's our lifestyle program. We initiate telehealth evaluations with myself and a dietitian. They go to an in-person visit with the weight clinic doctor, who's a medical doctor who specializes in obesity. All pediatricians. They attend monthly telehealth group sessions with the dietitian, and they do preoperative testing, including an endoscopy, a DEXA scan, and EKG, and blood work. Then they see our psychologist, and then our board meets and clear the patient for surgery. So it's a pretty straightforward program. It does take a lot of coordination, because there's a lot of groups and different departments working together, but it runs pretty smoothly. This is what happens after our teaching session. So after that information session, about 66% of the kids go on to have surgery. About 8% join the medical program. 13% end up dropping out, and 13% just don't even start. They're not interested. They're not ready for that. Many of them do come back, and we're studying now, and some of them do end up going into the medical program. Some of those that drop out are not interested. We're looking at that data right now. It ends up that to get through our program actually takes a year. Even though it's set up to be a 6-month program, when we looked at the data, what we found out is that the average days from teaching session to surgery was a year. It's even longer in younger kids. So the younger they are, the longer it takes them to get through our program. And then the kids over 20 are mostly kids with severe disabilities, so it takes them longer too. What does our population look like? It's actually 59% female. We have a lot of boys in our program. It's 50% Hispanic, and 60% have Medicaid. Average age is about 16, and the average BMI is 48, so they're fairly heavy. And 70% of them have sleep apnea and insulin resistance. So these kids are not healthy kids. These are kids with metabolic disease. About 50% of them have fatty liver disease, and 10% have diabetes. And when you look at our outcomes, these are our patients before surgery, and you can see most of them have class 3 obesity, so a BMI of 140% of the 95th percentile. And after between 6 months and 5 years follow-up, what we find is that there's still a significant number who still have severe obesity, about 50%. And then there's 50% who have no obesity or class 1 obesity. So the LPCH group program is led by an RD. It's designed to improve eating habits and activity. They participate in setting monthly goals, and it runs both pre-op and post-op. So they do 3 months pre-op and 4 months post-op. This is our nutrition goals I talked about. Anyone can do this. If you want to lose some weight, you can try it. It doesn't really work for weight loss, but it's not unhealthy. You're drinking lots of extra water. You're drinking protein. You're eating protein, and you're exercising 60 minutes. And what I tell the kids is, if you increase all of them. So if you're going to exercise 90 minutes, you need 90 grams of protein and 90 ounces of water. These are the minimums, though. Some kids will need more, some will need less, and we adjust that as we go. It's nothing wrong with stopping sodas and juice and stopping chips. And then we have them eat 3 to 5 small meals a day. And that's really a post-sleeve thing, whereas if you eat regularly after a sleeve, you lose more weight. And then we start them on a multivitamin. Again, getting a scale, a water bottle, and a pill box are recommended. Now we're going to be giving those to the kids. We're still setting up the program, but again, we did get funding to do that. And then we have them buy their vitamins. The sleeve takes about an hour to 2, usually about 90 minutes. And the gastric bypass takes about 2 to 3 hours. We do them all laparoscopically at the Children's Hospital because we don't have a robot. That's the only reason. Otherwise, I do them on a robot. And they recover in the hospital 1 to 2 nights. They are seen by physical therapy and the dietitian while they're in the hospital, and then they start on a 2-week liquid diet, which is probably the hardest thing they do. We send them home on ursodiol to prevent gallstones. We send them home on omeprazole to prevent reflux. And then we give them Reglan for nausea and polyethylene glycol for constipation, as well as Senna. And they have very few complications. In the last 5 years, we've done over 200 patients, and we've had about 5 complications, only 1 major. So it's a very safe procedure in kids, and the weight loss is excellent. Postoperative appointments, we see them regularly, 1 to 2 weeks. 6 weeks, 3 months, 6 months. We do regular lab checks at 3 and 6 months, and then at a year, we repeat the sleep study and the DEXA scan as well. And then we see them annually after, until they're 21, 26. It depends on the kid. We don't have an absolute cutoff for transition, but when the kid is transitioning their other care outside of the Children's Hospital or away from their pediatrician, then we usually transition them to the adult side. What are the complications? First 10 days, they can have some nausea. That's why we use the Reglan. It's gotten a lot better with Ament or Amend or whatever that medication we're using before anesthesia. And then the first week, we give them some Advil and Tylenol for pain. There is a risk of leaks. It's very small, and then a risk of infection, bleeding, or blood clots in any population, but blood clots are much less in the pediatric population. So in terms of risks after surgery, it's actually much less than in adults and even in young adults. Late complications, the things kids remember and they complain about the most is really the complications to rapid weight loss. We see it with medications. We see it with bypass and sleeve, and we also see it just when we put them on the 60-60-60 rule and they lose a lot of weight. And what they complain about is being tired, having thinning hair, and they're really moody, and they often have constipation as well. So those are the biggest complaints the kids have, and all of those are related to simply losing weight. We also get a lot of complaints about inadequate weight loss, and now we have like a lot of things we can do for that. So now we can use medications, we can use surgery, and we can, and I'll show you at the end, we do both, whatever we need to do to help them get all the weight off. They can develop gallstones. We see it a lot more often after the rapid weight loss from diet or medications, because after surgery, we're using the ursodiol. And so we don't see it that often after surgery, but we do see it after the other treatments. And in the bypass and the sleeve, you can see nutritional deficiencies. Incisional hernias are very rare. Again, this is done through 5 small incisions, 1 12-millimeter port. So they're really very rare to have incisional hernias. And then they can get kidney stones. In the bypass, I already talked about the reoperations due to obstruction, gallstones, kidney stones, and ulcers. They also are at risk for alcohol and drug addiction. Recent study just came out, which is really interesting, which showed that actually, if you look at alcohol use disorders, they actually are lower in post-bypass and sleeve patients than they are in comparable patients with obesity. So it looks like but I do know that gastric bypass, kids who have gastric bypass are at higher risk for developing alcohol addiction, especially if it's in their family. There's also a risk of anastomotic ulcers if they're exposed to smoking. And all of this makes sense because kids are going to go off to college, some of them, and when they go off to college, there's a lot of pressure to smoke and drink. So it's not unusual that if you have a bypass which predisposes you to addiction, you might be more likely to develop it in college. In the sleeve, there's a risk of reflux, and we do recommend endoscopic screening before they transition to an adult program. And then there's a risk of reoperation. Usually it's for gallstones or reflux. So here's some examples. Example 1 is a 17-year-old Hispanic female who came to us with a BMI of 40. She started to develop obesity in her teens, and she had PCOS, insulin resistance, a lot of knee pain, and depression. She underwent a sleeve and lost 16% of her total body weight. And then she started to regain weight. And we started medications. We used semaglutide, which is also called Wegovy or Ozempic. And in her case, it was Wegovy, and she lost another 18% total body weight for a total weight loss of 34%. She got down to a normal BMI and has maintained that, but has also stayed on semaglutide. Another case was a 12-year-old, white male who actually lives up in Tahoe. And this kid was he was bullied a lot. He loved swimming, but he couldn't go swimming in the lake because he had a lot of fat, and he was very self-conscious. He also had sleep apnea, NASH, depression, celiac, and had his tonsils out and still had sleep apnea. So we did a sleeve gastrectomy. He lost 26% of his total body weight at 9 months. Summer came, he was able to swim in the lake, very happy kid, much improved quality of life. Another kid was a 16-year-old African-American girl who came to us with a BMI of 54, and she had a very good response to sleeve gastrectomy. She lost weight and continues to lose weight, and she's now actually has a normal weight. I need to update this slide. And she had hypertension, sleep apnea, and insulin resistance and NASH, which have all gone away. Case 4 is a teen who had inadequate response to a sleeve. He actually had a pretty good response to a sleeve. He lost 14% total body weight, but then he started to regain immediately. And we see this. We started medications. We used medications for about a year and a half. Didn't really have a great response to semaglutide. So he came back and he said, I want to bypass. We did a bypass. He lost another 36% of his total body weight. Do not try this in adults. It doesn't work. I don't know why it works in kids, but it does. The bypass is very effective as an operation to use when patients regain weight. Usually in adults, if they don't have reflux, you'll use a biliopancreatic diversion to get better weight loss. So why is metabolic and bariatric surgery? It provides sustained weight loss, and it changes your internal signals for hunger, satiety, and metabolism. It increases life expectancy, an average of 6 years. It's more effective in children than adults. And you see a 95% resolution or improvement in comorbidities. And the bottom line is it's recommended by the AAP and the ASMBS in children of any age who meet BMI criteria. So that's everything you ever wanted to know about adolescent bariatric surgery. I'll take more questions about it at the end. Now I'm going to talk about how did I become a pediatric bariatric surgeon. Do you remember the beginning of the talk? Remember my disclosures? I love children. I always wanted to be a pediatric surgeon. I have 4 boys and a supportive husband, 1 granddaughter, and I work part-time. So let me tell you how I got here. first of all, I went to Wellesley College. I wanted to spend junior year abroad, and I was a pre-med, so they were like, well, you can go for a semester maybe. I'm like, no, I'm going for the year. I'll see you later. And I came back and took 3 classes, 3 like lab courses my senior year, and it was miserable. And but I got through it because, you know, sometimes you just got to do what you want to do. So you do it. I got married. This was my husband. He doesn't look quite like this anymore. You saw in the other picture. But I fell in love with him that way. And then I started medical school 10 days after getting married and going on a hiking trip for our honeymoon. I started medical school. And in medical school, I attended this talk. I think I was a first-year medical student, and there were all these fellows and residents there. And I said, you know, when's the best time to have children? They're like, right now, just do it now. I'm like, okay. So I had a baby in 1991. That's Jake. He's my oldest. And then I applied to residency, and I wanted to be a pediatric surgeon. So I looked for a residency that could get me into pediatric surgery. Now, back at Wellesley, I had discovered that I hated working in the lab. So I was going to try to do some kind of like a broad thing for my research time, or I wasn't really sure, but I knew I had to do some research time and get some research under my belt. But the program needed someone to go straight through, and I'm like, okay, fine, I'll just go straight through. I can do it after. And I went to MGH partially because Patricia Donahoe was there, and she's a very famous pediatric surgeon, for those of you who don't know her. And she's still working at age 80 and still an incredible mentor. And Susie Briggs was there, who is a trauma and global surgeon who was also incredibly supportive of women in surgery. So we took every other night call for 5 years. I had a kid at home, as you know, and a husband. And then I had another baby a year before I graduated. So senior year, I got more sleep in the hospital, because it was in-house call then, than I did at home. And my poor husband endured raising a newborn alone. And I'm mostly going to talk about the good side of this, but this was hard. You know, I had postpartum depression during my chief year. I had a baby at home. It was difficult. And I know we heard all about that at the last meeting, at the last grand rounds with Carrie's talk about depression and addiction. And I'm not even going to pretend that I understand what she went through, but I'm going to keep this positive, and I'm going to talk about all the good things. So this kid was amazing. He's the one that can eat 4,000 calories a day. And what I learned is, don't be afraid to take an unconventional path. Not everybody has kids in medical school, but be prepared when it makes things harder. Because certainly being a senior resident with 2 children at home was not easy. So then I went out looking for a job, and I knew I wanted to work part-time because I had 2 kids at home. I was thinking about fellowship, of course, but the fellowship that I could do was the one in Boston, which was Children's Hospital. It was 123 hours a week. And after being on call in-house for that many years, I didn't want to do that to my kids. And so I said, okay, I'm just going to be a general surgeon for now. So I didn't do a fellowship, although a lot of people were doing them at that time. I just took over for Mike Margulies and Ron Malt and Edwin Carter, who were retiring. So these 3 older surgeons, they were doing breast and a lot of endoscopy and a lot of colon surgery and some hernias, basically good old solid general surgery. So I took over for them, and that's what I became. I became a general surgeon. And I loved it. I loved breast surgery. I got to see my patients every 3 to 6 months. You know, they were all high risk. I didn't really like the surgery. It was kind of boring, but I did like the contact with patients. And then this guy, Andy Warshaw, who had hired me as an experiment because I was part-time, he said, you're going to do bariatric surgery. And I said, yeah, no, I don't think so. What is that? I honestly didn't know what it was. He's like, it's surgery for obesity. I'm like, yeah, that's like plastic. I'm not going to do that. So he asked me 3 times, and the 3rd time I was like, okay, fine. So he sent me over to meet this guy, Lee Kaplan. And he sent me out to see Sheldon Randall, who was a bariatric surgeon in the community. He'd been practicing for 20 years, and he was doing open gastric bypasses. And I went to watch him operate, and I'm like, wow, this is a pretty cool operation. You know, he could get in there with his hands and like make this magic happen. I was like, wow. And then I went to his clinic, and this patient came in, and I said, well, you know, why did you have bariatric surgery? She's like, well, I used to have diabetes, and I used to have hypertension, and I don't have any of that anymore. And she's like, I'm healthy. I feel good. I can get down on the ground with my grandkids. I was like, wow, it cured diabetes? And then I was like, whoa, this is crazy. So I went to the ASMBS in 1999, and I was impressed that there was an operation that could actually cure diabetes. And at the time, you know, they all said it was restriction and malabsorption. And I was like, okay, but how does that cure diabetes 24 hours after surgery? Like, that doesn't make any sense. And I think there were a lot of people thinking the same thing. And this guy, Lee Kaplan, is the one that came up with that, with the thermostat idea, with the set point theory. And, you know, it all sort of clicked over time as we started to realize that there were these hormones involved. And I just thought it was fascinating, and I got really excited about it. Stephanie Sogg and Sue Cummings were our psychologist and dietitian. We started this program called the Weight Center, and it was really exciting to be part of this, the start of this program, and to be the one who was going to bring laparoscopic surgery to the front. So Shelley was doing open bariatric surgery, so we started doing open bariatric surgery at Mass General in 1999. And then we trained. I went and trained to become a laparoscopic bariatric surgeon on my own. So I was doing lap choles. That was about the extent of my laparoscopic skills. So I observed. I went around the country and saw like 3 different people doing it. And I said, oh, that way looks like something I could do. And Phil Schauer was the one that was doing a technique that I thought I could learn. And then I started studying on the simulator. I did a couple of pig labs. It took me like 5 hours to barely do a bypass on a pig. And then I went in a mini fellowship. I went down twice to Pennsylvania and operated for 3 days straight with Phil Schauer, who had a big program and fellows and everything. And he wanted me to do a fellowship, like a 6-week fellowship or something, but I had, you know, 2 kids at home. I'm like, I can't do that. So, so I just learned. And then he came up for our first case, and Dave Ratner helped me, who was my chief and also an excellent laparoscopic surgeon. And we started doing laparoscopic bariatric surgery. And it was amazing. And then I had another kid, because it had been 6 years, you know, it's time for another baby. And what I learned is how to learn a new operation. And it's likely that you will need to do this in your career. The sleeve gastrectomy didn't exist when I went through residency. Endoscopy did. I do a lot of endoscopies. But the gastric bypass laparoscopically wasn't done in my institution. You are always going to have to learn new operations, because the operations you're doing today probably won't be done when you're older. So the most important thing you can learn during residency is how to learn an operation. And you also need to understand that it's okay to pivot your career, and it's okay to take the opportunities. And if your boss says, I want you to learn this, don't necessarily walk away and say, no, I'm not going to do that. Or if you do, you might want to come back and consider it, because sometimes they're right. And I have to thank Andy Warshaw for sending me down this path. So in my mid-career, I trained these 2 and then hired them to work with me. I took over doing revisional gastric bypass, and they did all the primary procedures. And then I started writing pediatric guidelines, because my patients were coming back to me and saying, my kids have obesity too, can you do anything for them? And I'm like, I don't know. So I started reading the literature. When I started reading the literature, I realized, oh, this is being done. We could do this. And I started writing the guidelines. And that was sort of my path to pediatric surgery. I also learned how to do hernias. It was one of those other things where Warshaw's like, you need to do this. So I did it. In 2005, I had, you know, it had been 5 years, I had another baby. It was my passion, and I really, I started developing the pediatric bariatric surgery program at Mass General. I also trained a lot of incredible surgeons along the way. Dr. Morales, I hired to come in and teach us how to do sleeves. And Pat Silla, Yulia Zak, who you may know, and Dana Tellum were all my fellows. And I was promoted to assistant professor. And then I became the director of the weight clinic. And I directed it with Kathleen Corey, who was a hepatologist. Fatima Cody Stanford is a med peds, incredible obesity medicine specialist. And Allison Hoppen was our pediatric lead. And I directed the weight center. And then I had another baby because it had been 6 years, right? So, I told you I love babies, you know, so what can I do? And the lessons I learned of this were really about leadership. Running the weight center was a big job. Starting pediatric bariatric surgery was a big job. And what I learned is that you have to have boots on the ground and you have to manage up. So you want to make sure you know what's going on in your program, and then you want to talk to your leaders and make sure they know what's going on in the program and they know what you're doing. And I also learned to pursue your passion and do what you're good at. So I loved doing revisional surgery. I loved doing laparoscopic surgery. I loved bringing laparoscopic hernias to Mass General as well. And then I loved pediatrics. My senior career, my husband was at DARPA, and we were living in Boston. He was living in Washington. We were going back and forth. And then that finished, and we decided it was time to make a move. And so he accepted a job for Toyota, and that brought us out here. So I moved here, and thanks to Sherry Wren and Mary Hahn, I was offered the opportunity to work at the VA, which was super great. But I kept coming over here and saying, yeah, I really want to work in your pediatric bariatric surgery program. I know you had one, you have one, you've had it since 2004. I want to be part of it. Can I be part of it? And eventually they said yes. So I also started at Lucille Packard Children's Hospital, and I was working quarter time or maybe 3/8 at the VA and 1/4 at the Children's Hospital. So that put together a half-time job. And as also a executive wife, which meant hosting a lot of parties, I was able to do all of it. So, and then I let my kids start having the babies. Because after all, you know, it's been 5 years, so I need another one. And they did. They indulged me. And then in 2019, I asked Dr. Dunn if I could move into the Division of Pediatric Surgery, which I did. And last year, I left the VA. I joined APSA, which is the American Academy of Pediatric Surgery, or whatever it is. And Dr. Matthias Brazzoni, who was running the program, left. And Stephanie and Gillian Fell and Claudia Mueller all pitched in to help me run the program. And so now I'm a pediatric surgeon. I made it. And I'm very happy about it. So I know it's silly, but I learned that perseverance is key. You know, it took me you know, 55 to get there, but I got there. Don't be afraid of change. You know, moving out here was one of the best things we ever did. And there's a lot of ways to become a pediatric surgeon. So the takeaways are: learn a new operation every year, ask for what you want, and take an unconventional path to get there, because we're all unique and we all have different ways of getting there. And what I didn't talk about is the hard times. There were a lot of hard times. Some of you know the stories. But the truth is that I had a tremendous amount of support from family and from colleagues, and I've been incredibly fortunate to make all my dreams come true. Thank you.